If you have questions as I'm going, then let me know. I'll try to man the chat, but you know, I probably won't do a good job of that. Okay. So thank you for joining the birth symposium. It's been great. There's lots of good information so far. I'm covering birth physiology, the sciencey side, what's physically happening for just certain aspects, and a few labor coping techniques. What I feel you need to know about birth that's not commonly known. Okay, so I'm Yasmin. I am a birth rights advocate, I guess is how I'm gonna label myself right now, because it's leading why I'm doing so many different things. So I am behind Delta Strength Doula. So I do doula work. I'm a breastfeeding counselor. I'm the founder of Rise Birth Center, which will hopefully be coming to UAE and the broader Middle East region. I'm doing Rise Positive Birth Stories, and they give another aspect. Well, what we see in media is not what we get in birth. So it's trying to get like the real story of birth out, and the positive aspect in birth doesn't have to be as we've been raised thinking it is. And then I'm also starting to do Rise expert interviews. So same thing, to get more information out from the people who know best about what we should know and what maybe is not in front and center as it should be. So today I'm going to cover how a baby first breathes, what triggers labor in the first place, what the hormone release is in labor, not what the hormones are, but how they're released and how that's different than artificial hormones. And then a couple of coping techniques. So I'll start with the breathing. When we have a fetus in the womb, its lungs are filled with millions of air sacs. Well, everybody's lungs are filled with millions of air sacs, the alveoli, and they are filled with a liquid. There's a fluid inside. So in the womb, the baby does a breathing motion, but the lungs are filled with a liquid. For neonate lungs, when the baby's born, there's this transition, a shift happens. So if we took a really close-in look at these air sacs and into the lungs, we'll see kind of what's pictured here. These are meant to be air sacs, and the fluid comes out. You can think of it as drained out, but it comes out and it joins the lung capillaries. So it's actually making the volume of the blood go up. So the fluid from the air sacs is increasing the volume of the blood. Okay, and then once it's leaving and it's left space, that's when you can breathe. That's when the air can come into the air sacs for the first time and start the lungs as we breathe as adults. Okay, so air sacs filled with lungs, or the fluid gets absorbed into the blood volume goes up, and then breath can come in. Everyone with me so far? I'm not seeing any gestures, so I'll carry on. So we have the blood volume increasing from the lung fluid. Okay, and then we also have blood increasing from the placenta. This is a cool photo. It's actually a zoomed in photo of the placenta itself, but we'll come back to kind of how these combine and why that's necessary. But for now, we've covered why there's extra blood volume coming from the lungs. And now I'm going to go into the fetal circulation so you know what's happening with the placenta right when the baby's born. Okay, so the circulation when the fetus is in the womb is, sorry for my images, but it's a very simplified picture so you can kind of get a better idea. So the lungs are mostly bypassed. They're not getting blood in circulation. They're at like 8%. 8% of the full system circulation is going into the lungs. You're about here, okay? There's a shunt that lets blood flow to the placenta and from the placenta. Sorry, there's extra noises. There's a shunt coming to the placenta and from the placenta, and it's open, so that's why you can have blood flowing in two directions. Again, lungs are getting bypassed. So that's the fetal circulation, and then when they're born, it switches more to how adults breathe. That shunt closes, so that means blood is no longer going to the placenta. You're only going to be getting blood from the placenta, okay? But I'll repeat that. You're still getting blood from the placenta after the baby's born. Blood is still coming from the placenta. So the shunt is closed, blood stops going from one way, and then the lungs start filling with this placenta blood as well. So I'm going to stop the share so I can show you more hand gestures, basically. So the blood from remember the liquid that was in the air sacs gets absorbed into the blood volume. We have a greater blood volume, and that starts filling the lungs and the full circulating system. And then we have the blood from the placenta that's also filling the lungs. So remember, as a fetus, the level is 8% of the circulation that's happening in the body is at 8%. To be able to breathe properly and start continuous breathing, you need to get to 55%. So that is quite a lot of blood that needs to start filling up the lungs for the first time. So you need both the increased volume from that fluid and you need the placenta blood. I can't really stress this enough. So you can start seeing why it's important to have the placenta blood continue. Along with needing to fill up the lungs, it's also filling up the capillaries in your fingers for the first time. So when a baby's born, they're not, or when this transitioning is happening and when the baby's in the womb, they're going to be a gray kind of dusky color. They don't have that high blood volume, so they don't have blood circulating through all areas of their body as they will when they're born. So these capillaries, the small ones on your fingers and your toes, they're going to get filled for the first time. And that's when you start seeing that pink color. Okay, so blood's still coming from placenta, volume's increasing, lungs are filling. When the lungs are filling up to that 55%, you're also getting from the placenta specifically, you're getting more red blood cells. Those more red blood cells are oxygenated, they have oxygen. So that higher level of oxygen is what turns on the respiratory system to say, keep breathing continuously. It's not practice breathing anymore, you have to continue. So the way you and I would breathe, where we're not thinking about it anymore, that's why you need to get up to that 55% level, so that you get the extra oxygen from the placenta and that the babies can breathe on their own without thinking about it. So that it's triggered to say, you need to start breathing continuously. That might be a lot. Is everybody still with me so far? Feel free to unmute yourself and let me know while I am sharing the screen again. Okay, I think we're good. So what starts labor in the first place is, what starts the breathing in the first place is when air comes in contact with receptors around the nose and the mouth. So when air comes in contact with receptors around the nose and the mouth, that's the first time the nitrogen molecules and gravity is hitting these receptors. And that's going to signal the baby to start transitioning. That's the signal that goes to the body to say, close that shunt. Blood only is coming from placenta. Don't release any more back to the placenta, and start increasing the blood volume so that baby can breathe with air and that we can get the liquid out and that there's space for air to come in. Okay, so it's why this is important and why we need to note this is because it makes a difference for how water babies look after they're born and how land babies look when they're born. So a land-born baby, if they're born head down, the head comes out first, and especially for first-time moms, it's usually another contraction or so before the rest of the body comes out. So while the head is out, but not the body, they're still getting this signal and they're still starting that transition. So when a baby from land comes out and is placed on mom's chest, their color is going to be slightly more pink and they're going to look slightly different and breathe slightly sooner, potentially, than a waterborne baby. Because a waterborne baby, the head comes out, but they're still in water. And then the body comes out, they're still in water. This is also explaining why a baby doesn't breathe underwater. There's no risk of that happening because these receptors have not been activated yet. Oh, I probably should have stopped sharing so you can see a little clearer. I just remembered I forgot to do a demonstration, so I'll come back and do that too. But so waterborne babies, they might be a little duskier for longer. It might take them slightly longer before they take their first inhale. Another interesting thing to note is that they exhale first. So they're spitting, swallowing, they're getting rid of whatever's in their system, which is why you don't need to suction for waterborne, for any babies, unless you're doing respiration. But anyway, they're born, they're going to be a bit of a different color until that blood starts getting all the way through. So there's the normal APGAR test or score, but that applies for land-born babies, really. If you have a breech-born baby, because their head comes out last as well, or you have a waterborne baby, there's a modified APGAR score so that your provider would know this is what still looks normal. And usually by that 5 minute, because the APGAR is done at 1 minute and 5 minutes. Usually by that 5 minutes anyway, the waterborne babies have the same, if not better, outcomes than the land babies. And it's from that transition just takes some time. So the 1 minute score might be a little lower because the color's not looking as good. They don't start breathing as fast necessarily, but by 5 minutes, it's cleared out. So it's just one more thing to know in case you're wanting a water birth to be aware of that. It will be fine. Okay, I think, yeah, okay. So I'm gonna summarize here. And actually while I do that, I'll do the bit of demonstration. The fetal state, shunts are open, blood is bypassing the lungs, blood goes back and forth to the placenta. For birth, the shunt closes, the lungs are filling with blood, and the blood is flowing only in one direction from the placenta. So you're still getting that blood. I will show you here. This is just really to hit in that what happens during birth. And I think I need to, oh, I have stopped sharing screen. Oh, sorry, okay. Carrying on then. Okay, so this is my lung. All right, and we need to get up to that 55% as I spoke about before. I have, oops, sorry. I have the blood coming in from the lung, say on the left. I've got the lung. I've got the fluid that's being drained coming out of this cup. I've got the blood from the placenta coming out of this cup. And again, I need to hit that blue mark to hit the 55% to turn on the regular breathing, to continue the respiratory, to do the continuous breathing and to have enough blood volume. So when the head first comes out, this is kind of what's happening. It's starting to fill up the lungs. Now, if I cut the cord, I'm not making it to that 55%. I'm not getting the lungs set up as it needs to be set up. I'm not necessarily making it possible for the baby to do continuous breathing. Obviously, we all know children who have had their the cord cut early, and of course they still breathe, but this is a risk. There's a risk of hypoxia if you don't get that rest of that cord blood. There's also a risk of, because when you take a supplement, infants don't, if you take a supplement, the infants aren't able to absorb that as well. So it's not as useful as that blood from the placenta directly. So the iron from the placenta really helps with lowering anemia, or there's more risk of anemia if you're not getting that cord blood, along with so many things. But one that's not talked about much is this filling of the lungs. So it's important to know that it's really setting up the lung system in the first place, the placental blood. So all of this can go into, for both providers and medical care providers, if you're doing early cord clamping. And I say early cord clamping instead of saying the word delayed cord clamping, because it's really delayed cord clamping is optimal cord clamping. And the early cord clamping is going to be causing these extra problems. So, you know, weigh the risks always. So this again is the summary that I've already gone through. I'll just pop it up here because you haven't seen it. And do we have questions on that? I'm going to move on to the next physiological thing. Don't know where the chat is. Oh yeah, there are some things coming in. Let's see. Okay, no questions. Just comments. Glad you're finding it useful. Okay, so how does labor start in the first place? There are probably many aspects, but one thing that is known is that baby lungs are fully developed. When the baby's lungs are fully developed in the womb, an enzyme is released from the fetal lung, and that goes to the brain reads it, and oxytocin is released to start the contracting of the uterus. So things to consider about this is if you want to, you know, induce because it's your due date. And I know that was covered earlier as well, which is great to really understand, like, What are the risks of induction? This is one of them, that potentially the baby's lungs aren't fully developed. Unless there's something emotionally stopping the mom from going in labor, she'll go in labor when the baby's lungs are developed and that enzyme is released, giving the message like, okay, baby's ready now. It will be able to breathe on its own when it comes out. So I think, don't worry, nothing else is multiple slides about the physiology. Now moving on to how the hormones are released. We've covered a lot today, what the hormones are and why they're helpful and, and things like that. But I'd like to take a minute to clarify where they're released to. So the location and where the endorphins get released is they're taken by a neurotransmitter down to specific parts of the uterus during different stages. So at the beginning, the endorphins go to the cervix because the cervix is what's moving. The cervix is opening, softening, dilating, effacing. So the neurotransmitters go there, or the endorphins go there. And then it goes to the side of the uterus. And then at the end, when you're pushing, it goes to the top of the uterus on the fundus to, help push the baby out. So the location, when you're in a natural birth, non-medicated birth, where these endorphins get placed, changes as your labor changes. Another thing, if you're doing natural non-medicated, the hormones are released in pulses. It's not a constant flow. It's a pulse as needed because they go down, gets read by receptors onto the uterus, message is sent back up. Okay, we're done with the cervix, now go to the next part, whatever, this is very basic terminology to think of it, but then it's still like it's reading itself and it's coming in pulses. Now, if you're taking an artificial medication or doing an augmentation or doing an induction with medication, it's flooding the system. So it doesn't go to all the different portions of the uterus as it would naturally, it just floods everywhere. So when that happens, then the receptors aren't as effective. And then they're not reading it as well. So the contractions aren't going to be as effective, or surges or waves. It also then stops crossing that brain-blood barrier to tell you, I need more pain relief. So that's why you're seeing inductions tend to be more painful, because you're not getting your own endorphins into the system to help deal with the feelings of it. Everyone good so far? Okay, now we'll go into a couple just coping techniques. So this is from Motherboard. I like these images, but just to show, is a hip squeeze. And I have not had a mother not love this. Some days I feel like I could just spend the entire labor doing a hip squeeze. So there was some talk about counter pressure earlier in the day, but it is a motion into the hips and up, okay? Into the hips and up. So you're kind of putting your palms together. And I'll stop sharing so you can see my pillow. So say this is the top of the hips, the inlet of the pelvis, the top corner of you, like your hip bones. You're putting your hands in and up at the same time. So you're kind of doing this motion, like up and in. And you just hold it throughout the contraction. Your fingers, to remember it, the birth partner's fingers would be kind of going towards each other. Okay. So pretty simple. Most people love it. And sometimes that changes through labor when they like being touched and when they like the feeling of it, or when they want that or don't want it. But for the most part, people love a hip squeeze, even when they're pregnant as well, because it takes some of the pressure off. So in this slide, you'll see when you're hitting on the inlet of the pelvis on those top bones, it opens the outlet of the pelvis a bit. So kind of think of it as a clothespin. This is the top inlet of the pelvis, and say my elbows are the outlet. I know this is not to scale, but outlet of the pelvis, you squeeze on it, it's going to open, or sorry, inlet of the pelvis, when you squeeze, it's going to open the outlet of the pelvis. Okay, so think of it like a clothespin slightly, and that comes into play as well with spinning babies techniques, and how, what do you want to move, the inlet or do you want to move the outlet, and then how do you need to put your feet and things. but that could be a whole nother session all on its own. Okay, so that's a very simple one. And then the next one, last one, I guess, is using a comb. So this is an acupressure point right on the top of your, what is this called? In your palm anyway, but right under the fingers where they come in. These are acupressure points, and you can put the teeth of your comb just, where are you, here? And squeeze. And you just hold it through a contraction. So this can be done on your own. Maybe somebody needs to remind you, but it can be done anytime. There's no contraindications for it. It's just a pressure point here. It's for releasing endorphins. Another one that's good is the bottom of your toe, right in the middle. It's an acupressure point, also for endorphins. There's many that are helpful in labor, like getting more, helping the uterus, how it feels. You know, if you're nauseous, if you need stronger contractions, there's many, but these can be used just to release endorphins, so it's safe to use at any time. All right. I've got quite a bit of time. I'll just cover what I put together for the Symposium. If you're watching till the end of the month, you can get 10% off any of my services, and then a birth plan session or a birth preferences session if you do a prenatal course. So let me know. You can get in touch with me from, these are the Delta Strength Doula sign or contacts, and then I'm also on Rise Birth at Instagram, or at Rise Birth on Instagram. But I'll stop sharing and see if there's any questions on this so far. If not, then I can give some more tips on things to prepare to write down for yourself and you and your partner. So, okay, I think we're okay. I'm just seeing some comments, not questions. So things to write down are ways you can prepare in advance. I like to, because when you get to the end of your pregnancy, it might get a bit uncomfortable, and you might be like there's more pressure a lot of times from medical profession or from the provider, say, well, let's induce. So I think a great idea is to, for every day over 40 weeks or 41 weeks or whenever you're just like, I'm done with this, give yourself something every day. So whether that's going to be a 3-hour break to be on the couch by yourself, whether it's going to be a day out to the movies, whether it's going to be a gift of some sort, whatever your love language is, write down a list of, if I go over 41 weeks, 41 plus 1, I'm getting this gift. 41 plus 2, I'm going to the spa. 41 plus 3, I'm doing this. So you have something to look forward to, and it gives you that extra motivation to just hold on. Because as we saw, it can make a difference to how things go and if lungs are ready. So if there's not a medically necessary reason to induce, then this is a way to keep you happier about that. Another thing that's good is with your partner, whoever's going to be there. Oh, I got a question. How long should we wait for cord clamping? Great question. So it's best to just wait till it's white, because then none of the blood coming in from the placenta is coming anymore. So while it's traveling through, there's going to be color. You're going to see the blood because the umbilical cord is a bit like transparent. It's opaque-ish transparent. Those are oxymorons, but anyway, you can see that there's still blood in. So when the blood stops coming from the placenta, the cord is going to be white. Another thing is when the placenta detaches from the wall, it's no longer functioning because the mother's body is what's helping it run, essentially. So when it detaches from the wall, but that's harder to know. So when it's born, when the placenta comes out, then you would know as well, like, well, it's not going to be still sending any blood because it's not still attached to the body. So either of those ways is good. Wait till it's white. Wait till the placenta's out. And there's also lotus birth. So some of the girls talked about it in our Birthing with Heart book, which you don't clamp it at all. They'd be better to talk to about that, but there's no reason that you have to clamp either necessarily. So it's for sure you're getting all the blood in if it's white or if the placenta is born. The list is a great idea. I went 40 plus 4 and had family pressure. That's the thing. I know one of the ladies, one of the authors had, or maybe it was one of my clients, had told their family that they were due a month after they were actually due for that reason. Especially if you go late, like if your family and your sister and your aunts, like if everyone goes late, you probably will too. And I know earlier today somebody mentioned if you have your period, if it usually comes a little bit later than the 28 days, then you probably also will go over things like that. So it's just, if nobody knows, nobody can say anything. So I thought that was a great idea. Another thing to write down, I was going to say earlier, so with your birth partner, whoever's going to be in the room with you, you would think, especially if it's your husband, you would think and hope that they know exactly the right thing to say, but they don't always. So it might be helpful for them to just have a list of things that you want to hear. So things like, you're doing a great job, I think you look beautiful. And as silly as it sounds to like write this down and give yourself these compliments to have your husband give you, or your birth partner, it can be really helpful in that moment to just know that their presence is there. And it helps them understand this is what they might need from me. This is what she might need from me. Okay. Yeah. Let's see. Any other questions? I think we're okay. All right. So I'm going to ask, so whoever's willing to unmute or chat back, if everything made sense for you. Okay. Thank you. Okay, I was sharing on Instagram as well. So if you need a recap of any of that immediately, it's there. Was that clear for everyone? Did that make sense to you? Did the imagery make sense? Did I lose any of you technically with anything?
No, thank you so much for always sharing your knowledge. It's always good information.
Yes, okay, yes, knowing the facts actually helps prepare. And it's not so much you prepare, it's just to know, like it's something we don't talk about much. And I'm wanting this message to get out more, that we need to be aware before making decisions for cord clamping and things, that there's a difference to what's happening internally for the baby. So I think it's helpful to know, even though we don't talk about it much. So yeah, that's it. I can be reached again on deltastrengthdoula.com, risebirthcenter.com, Instagram at risebirth. I think Twitter is Rise Birth Center. The book is amazing, having read through it multiple times. The book's amazing. And yeah, I guess I didn't know when starting out what it would become. And it's just, yeah, I love that there's aspects from everything. And I think it's so relatable in some way or another to everybody who would pick it up, even if you're not a female, like maybe your mother, maybe your sister, maybe your wife, maybe, whoever, how to better support them from reading that. And yeah, it was a beautiful book.
And I forgot to mention earlier also, but I love that we all come from different backgrounds, different cultures, even different religions. Mm-hmm. And the book flowed so well, because at the end of the day, we all have this one thing in common, and it's this power, to birth a child, and our experiences are vastly different, but we are all connected in one way or another. And it's really amazing, I thought.
Yeah, we did forget to mention that, but I think that helps, because that's what makes it more relatable as well. And there's no mention saying, do it this way, do it that way. It's just know this, know that, here's my experience, here's what I went through, you're not alone. So much to be, that's valuable. At some point in time, you'll find something that's really valuable or resonates with you in some way.
And I know Dr. Sulaf is here, but you have 1 minute. So tell us quickly, why Rice Birth Center? What is Rice Birth Center?
Why did I pick the name Rice Birth Center?
Well, what is it? What's
It's a
work in progress.
It's a planned birth center. So it'd be an outside facility for midwifery-led births in the Middle East, which is non-existent. And more than non-existent having birth center is we don't have midwifery-led births. In UAE, there's one option, but it's still oversaw by doctors. And the care and how care is provided between doctors and midwives is very different, because one is educated in emergencies. They'll try to prevent anything from happening, which is understandable as you see more you're wanting to prevent something happening again. But that's not accounting for like the 90+% of women who have perfectly natural births and can do it perfectly natural. So the midwives react if something's going off track, they react and still keep you safe. So it's a different way to provide care completely. And the outcomes of this different way to provide care is much lower interventions, much lower rate of cesareans, much higher rate of satisfaction for mothers, all sorts of things. So I'm trying to bring the concept here.
And so everybody follow Rice Birth Center so we can find out any new developments. And I know she posts great YouTube videos and great interviews all the time. So do follow Yasmin on her sites. They're all amazing information always. And thank you for coming. And we're going to have Dr. Sulov. Yay, she's here now.